Hey, and we may do some things a little bit different today, only because our presenter isn't on the call quite yet. And so welcome to our early echo session of the new year 2025. So this is our first one of this network. We are recording today's session. It will be stored on our Canvas page as well as our YouTube channel, so you can always go back and review that. We'd love it if you would turn on your cameras so we can just get to know each other. That is one of the main things about an Echo, is trying to build that that networking, that professional networking in a virtual way. So I see Gabby Castro's name come up on mine. I know that I could reach out to her and where she's from. And that's why we ask if you'll rename your profile and again, just turn on your camera. We do talk about some sensitive topics, and today is going to be one of those really sensitive topics, how to have difficult conversations with families. So just avoid using any identifiable information. If you have any questions about what that entails, you can reach out to a hub member. They all have an asterisk in front of their name, or they will now. And it just makes them easier to find on our chat list. Key components of an Echo, if you've never attended, is we do always have a presentation, and then we have a case, and we then discuss that case. We're able to then share your guys' amazing recommendations and resources, and again, just continuing to build that network up. We have amazing colleagues on here from North Dakota and Montana and Idaho and Utah. So it's always great to know others that are out in the field working in early intervention and getting different perspectives. So those breakout rooms and case presentations are always a great way to just share your knowledge as well as learn new information. If you don't know how to rename your profile or raise your hand, I'm going to quickly highlight these two slides. You can do that, but we've all been on Zoom for quite a while and probably know that really well. In order to get a credit of attendance, we do ask that you fill out a survey. Throughout today's session, the survey and the PowerPoints will be dropped in. Those surveys are what we take back to our funders to say all the amazing work that this Echo does. It's a way that we keep those going for free. So thank you so much to everybody who always fills those out. It does give us information and how to change those sessions. So we do base our topics on suggestions that participants provide us, the information that you guys want to receive. Canvas is where we store all of our materials. So if you want access to our Canvas page, just email earlyecho@usu.edu to request that, and we will get you signed up for our Canvas page. We are always looking for case studies. I know that sometimes it's not always easy to share a case. So if you have a case and you would like us to present that, just reach out to us at earlyecho@aggies.usu.edu, and we will get you set up for doing a case. We have social media that we share information about our sessions, information that is provided to us by others. So if you want to take a minute and follow us on Facebook, Instagram, or LinkedIn, that would be great. We also do have an extra Facebook page group that we're hoping to continue those conversations on. So if you have something was interesting in today's session and you want to continue to discuss it, join that Facebook group and we can keep those conversations going.
I am so grateful to be here. I've had a long-standing relationship with Kristen Alberg, and she and I worked together for a long time, and now she invited me here. So I have deep gratitude and appreciation for all the work that you guys do. What you will know about me is I'm an associate professor at University of Utah in general pediatrics now. I'm no longer a hospitalist. And I run the large regional Fragile X Center, which is new as of March. So I will give a plug at the end that if anybody has patients or clients that they know with Fragile X syndrome, I'm here for you to support you in every way. And we're really hands-on with what we're doing for these patients. There's lots of treatment. But that being said, my other hat is to talk with clinicians about how to have difficult conversations and how to navigate conflict. So I'm really excited to talk to you about that today. If it's Janelle, do you want me to share my slides or are you going to be sharing? I am fine either way.
You are free to share your slides unless you want me to share them. Sometimes it's easier because you know when you want to move on to the next one.
Exactly. So let me just get this in a good presentation mode. Does that look right to all of you? Okay, good. I see nodding.
Yep.
So let's kind of take a deep dive into navigating difficult conversations for us as care providers. And you know that each and every family is different. I feel like if we teach how to do one of these, it's going to be different the next time. So just building that skill set. And if there's one thing I can encourage all of us today, and I do the same thing all the time, it's practice these skills. Maybe in one session, you're going to focus on one aspect and then, work on it over time to make sure that you're building your skill set for all the pieces of this. So, advocating for trusting conversation, it really starts with our first encounter with the family. I know that this is a large regional conversation, so it might be hard for me to see comments, but why don't you think kind of just in your head, what are the things we do to make great connections with families? And feel free to put that in the chat, and maybe Janelle can read responses to me if I can't see them.
Yep, I'll be glad to.
Great, thank you. I like to be really interactive. So. Oh, I see one. Reflective listening, I love that. And sometimes reflective listening goes a little deeper than just saying, oh, so you said, and just mirroring it back, but actually, giving some synthesis in that, right? I think that's fantastic. Open-ended questions, priceless. Like, what are you really thinking? Like, what is my assumption of what you're thinking? Then what are you actually thinking? So that's wonderful. And then, yeah, body language validation. See, you guys are great at this. Ooh, acknowledging expertise. I can tell you as the mom of a patient who has special needs, it can be very frustrating when your parental expertise gets dismissed. So I love that. Getting to know people, right? And that is my next point. So let me move on to the next slide. Maybe let's try to move on to the next slide. There we go. So I like to think about what we call the house model of shared decision making. So we have all been trained in a certain model, right? When we went through all our schooling, when we learned how to be great providers of the care that we provide for these young children, we have that medical explanatory model in our head. We bring expertise from our past lives. And so if you grew up in a diverse community or a rural community, you carry that with you. And it's important for all of us to kind of know who we are and know what our lens is so that we can then elicit what the family's lens is and provide better care for them. Then the family has their own explanatory model. And I really want to emphasize that for those of us who are working like on Navajo Nation or Wind River or, let's say some rural community deep in Idaho, the family explanatory model might be quite different than our medical explanatory model. And so if we're building this relationship that's going to sort of culminate over time, and at certain points in this relationship, we know that we're going to have to share some tough news, right? So let's start building this house so that, we can create that shared decision making when we need to. And the way to do that, I think of every conversation and interaction I have with a family as kind of the floorboards or like the joists of that relationship. So if a family tells me like, oh, he really likes trucks, I'm always using that piece of information to like, okay, that's going to be a great motivator. That's going to be something that we keep in mind if we're having a tough conversation later, let's bring that into it. If a parent tells you that, they're really struggling with some aspect of social determinants of health, be that financial or, working with their insurance or, making their sliding scale payments or whatever it is, file that away, because that family will trust you a lot more when it comes to that hard time where you have to have that really tough conversation versus if those are just all kind of asides. So when I'm outpatient, each of my patients has a sticky note and I have a lot of information. And I always say, I'm going to remember this about all my patients because I adore every single one of them. But when it comes down to it, like we see a lot of people. And so having that prompt and that reminder is just really helpful to me. So I don't know how you do it. Like I do try to review my notes before every visit so that we're not starting at the beginning again. And I really try to make sure that I know that patient's medical, social, and other history before I go into that space. So providing difficult information or things that you might think would result in a conflict or could be difficult for anyone to take. So I remember back to our very first early intervention visit, and the nurse who came in with our team noted that my son, had some visual appearance differences that maybe we didn't appreciate. And yes, pediatricians should never treat their own kids because all I just see is my son, who I love. So, she's going to have to share this tough news with me that it might be a good idea to see our medical provider for a medical evaluation, not just early intervention evaluation. So I like to really think about it in these steps that are here. So let's get ready and prepare for having that conversation. So I'm going to do a mental check-in with myself, and I'm going to say, do I have what I need to make this conversation go forward? Do I have the information that I need to be fully apprised of it? Do I have the right people in the room? And do we have a place where we can talk? If the child is screaming right now, like, is this a good time to have this conversation? Timing is everything. And we'll go over that in a few slides, talk about our sense of timing, but really setting the stage, making sure that the right people are there. And then understanding what the patient knows. So if I have a patient and they have been to multiple providers, and let's say that they've seen outpatient PT through a center, and they've seen you, and they've seen an orthopedist, and they've seen neurology. And so you have a lot of different inputs. And if you're anything like me, like you don't always have access to all that information. So I really like to check in and say, hey, what have you heard so far about this situation? And just setting the stage so I'm not repeating information and I'm not negating the complexities that one provider has maybe already, presented to that patient. So tell me what you know right now. What are you understanding about your son's condition? So that's great stage setting. And then so some people call this the headline or headline rule. Some people call it shot across the bow. But the important thing is, like, I think sometimes we try to soften things so much that we forget to like put the true impact of what are we actually trying to say. So, you know, I can see, based on what you've told me and, you know, what I'm seeing with him is that, you know, we have a known, let's say, neurodegenerative disorder, and it looks like we're sort of plateauing on our milestones right now. Did I get that right? And parents kind of already have in the back of their head a worst case scenario. So I think softening it so much that we're not being clear isn't really helpful to them, if that makes sense. So giving that headline so that we can work through it. I really try to avoid as much jargon as possible, but keeping in mind that we have a large swath of health literacy, and just because someone appears one way doesn't mean their health literacy is commensurate with that. So I have this really great story. I had a baby with Down syndrome who was in the hospital, and I was a hospitalist at the time. And the family was from Four Corners and, you know, Navajo family. And so our team was like, your baby has a bug, and that bug, and they were just going really simple. And I could kind of tell, like, just by the family was not nodding along. They were just kind of very still in their own way, kind of looking down and not making eye contact and very quiet. So my well-meaning resident went on to explain in great non-specific detail about pneumonia and empyema, an infection of the pleural space, and that we would need a chest tube, but it was all very vague. And the team then tromped out of the room, and I checked in with the parents, and I'm like, do you have any questions? Like, I feel like there might be more information that you want. And it turns out the mom was a microbiologist, and the dad was like like big in IT, and they really wanted details. And so they were like, okay, if she has a bacterial pneumonia and we're taking a sample, how often are those back tech plates read? And I'm like, oh, they want to go deep. And so being able to meet them on their level just totally changed the game. And all of a sudden you saw us engaging in a way that was like much more confidence, family felt much more empowered, and it was a much better relationship. So really trying to find that literacy level, avoiding jargon, but being able to provide it if that's what the family needs. And then after you give that headline, stop. Stop and check in. We really want to know how the family's feeling, how they're processing that information. So, you know, if somebody visually is shaken by what you've said, you can say, you know, it looks like that was really hard information. Like, what are you thinking right now? Expect that response to be emotion. And this is the piece where I really wanted to emphasize, like, being able to empathize with them and acknowledge that emotion first and foremost. Like, yeah, I know that's really hard. It sounds like it even might be a little bit scary for you. Are you worried that, you know, he's going to regress further from where we're at now? And kind of, calling out that emotion. We don't have to get it right, but we do have to like ask about it and help process that, because people respond first on an emotional level and then second on an intellectual level. And they will always remember how you made them feel in that moment. Like those diagnostic, I remember getting that call on the phone on a Friday night at 5 p.m. telling me that my husband or my baby had a genetic syndrome. And I remember how that doctor made me feel. She didn't feel hurried. She acknowledged that this was really hard information, and she let me sit with it, and she sat in my pain with me. That makes all the difference. And you can create a positive cadence. You can lay some really strong floorboards if you're really engaged with that emotion. It doesn't mean to have more emotion than they have in that moment or to perseverate on it. But a lot of times, and again, I'll get into this in a minute, we as providers, we kind of want to skip over that. the doctors are the worst at this. Like, it's not you, it's the physicians, where they are very hesitant to allow that emotion to bubble up and be acknowledged, because we're fixers. We're not feelers. And then equipping the patient for the next steps. What can I do to make this easier? Are there folks you want me to talk to? These are the next steps I'm thinking about. And before you go into the situation, having a little bit of a plan, some things that you can offer so that you can help continue the conversation and make that family feel like they're not going to be alone in this. So especially physicians, we give that bad news. We say, oh, you need to see oncology, or, oh, you need to see, neuromuscular, or whatever it is. And then we leave. Here's a referral, bye. So I do a lot of diagnostics in Fragile X Clinic, and I have, some small number of patients who actually don't have Fragile X, but need to come in for my testing and counseling. And at the end of it, I always tell every family, look, I did not come up with the answer for what your child has, but I do have a plan for next steps, and know that I'm always here for you to help you make those connections until you get the answers that you need. So, questions about that before we move on? Okay. So, sometimes that difficult news can lead to a conflict or a disagreement. So maybe I can ask all of you, why are we so uncomfortable with that conflict or engaging in that situation that might have distress in it? Oh, a lot of people weighing. Yeah, how they might react, uncertainty to say or do the right thing. Oh, who said that? That was really good. Because it's awkward and difficult to give the right answer. We are really afraid, and we'll talk about this at the very end about power differentials. We are really afraid that we don't know, that we might say something wrong, or that we might not give the perfectly textbook right answer. And so we'll talk about that when we talk about power. And then sometimes it's just hard to know what to say, and we don't want to make it worse. So those are great answers. I am a big fan of knowing yourself before going into these situations. So I am going to assign some homework for us. And in this, I want to have us reflect a little bit on what our conflict styles might be. And I'll give you a spoiler alert. Most of us probably live in the avoiding and accommodating range. And that's because we're helpers. We want to do the right thing for people. And so we want to avoid those conflicts at all costs and just fix it. And that is not a bad thing. That gives us some really good strengths that I'll talk about in a minute. But most of us probably live in that range. And I'll show you how we can kind of know that. So computers, think about your surgeons that you might know, these, or maybe a lawyer. Assertive, maybe uncooperative, I'm in it to win it, it's my way or the highway, kind of power-oriented folks. Not a ton of that in medicine. Collaborators, this is great. And this was my aspiration. I'm like, oh, I should be more of a collaborator. These are people who are really assertive. They surface the conflicts. They're really cooperative. They fully satisfy the concerns of both parties. And it's kind of us saying, hey, let's figure this out together. 2 heads are better than 1. So this sounds like the ultimate perfect thing, right? Which it is, until you realize this takes a huge amount of mental energy, and it takes a really long time. So not practical on a day-to-day basis. And it's not actually a mode that we enter into in the workspace as much as maybe we could. And that's okay. Like, I don't want anyone to think that any of these are better or worse. We should use the whole palette. Compromising, this is immediate, this is quick, it's kind of a balance between assertive and cooperative, but it's like, okay, let's make a deal. But this is really great for picking what we eat for lunch. It's maybe not so great when we're picking a plan of care for a critically ill baby or something like that. So let's make a deal. And then avoiders, that's all of us probably. I would say if I had to guess, probably 85% of us are avoiders. It tends to be pretty unassertive and it's uncooperative because we're not necessarily engaging in the conflict. And it can be just passed under the rug. And so everybody in the situation feels unease, but nobody's willing to address it. And this is part of Utah nice, or, whatever you want to call it. This is, I'll think about it tomorrow. But avoiders have a superpower because if it's not the right time to engage, we're good at saying, I'm going to sit with this discomfort and then I will engage in this at a time that's better for all of us. As long as we don't put it off so much that we're not engaging at all. So it gives us a lot of time for preparation, a lot of time for thinking about getting the right solutions. So it can be a wonderful tool. So shout out to those of us who are avoiding. And then accommodators, this is unassertive and cooperative. It's sort of the opposite of a computer. This is like, a parent when you come home from college who's like, give me your laundry, I'll do it. Let me make you dinner. I'm going to pack some frozen stuff for you. Super great. But that person can eventually get really frustrated. It would be my pleasure. Of course, I'll sit on that committee. This can be exhausting, can lead to burnout, and maybe doesn't give your client or your patient like the input that they need to hear from you, the expert. It is important for us to think about when to engage in this conflict type conversation. And when I say conflict, I don't want you to think in your head like, oh, I'm going to have a fight with this patient. That's not what it's about. It's like, we're going to have a discussion about a care plan, and we may have two different perspectives about what we should be doing next, or whether, for example, in my clinic, like whether we're going to do these vaccines or whatever. Doesn't have to be a big thing. And the more you practice it, the more each conflict never rises to a level that causes us distress. And therefore, it doesn't rise to the level that causes your family, your patient, distress. So that's why we like to become experts at this. But I don't engage in these things unless it requires a decision to be made. So a patient and family can be really frustrated about care that another doctor provided or something like that. If it's not going to change the management plan, I do my empathetic listening, I mirror them back, but I don't engage in a conflict around it. I don't try to explain what the other person's doing because I want to keep those floorboards of the house really solid. So, I use that shared decision making only when we really need to. Does that make sense? Timing is everything. So this is the roadmap that I really want us to break apart and then think about in terms of these are pieces I'm going to practice, and I'm going to practice a different one each day. So we may think it's really easy to just notice a tension or disagreement, but I can't tell you how many times I walk into a room, I kind of feel like there's something there, and I'm like, I'm just going to pretend I don't feel that. And I move on with my day because I think it's going to be faster, right? When in reality, if you have a family that's not engaging with you through a whole visit, you're sort of wasting that visit. They're maybe not getting the instructions that they're going to need to apply to their child. It's just, you're wasting your time. So taking 5 minutes out to do a check-in at the beginning and notice that tension or disagreement is going to pay dividends at the end. And every time a family gets through a really hard thing with you, you just put more floorboards, more joists, more foundation into your house. So really important to sort of engage in that way. So noticing, one day, just spend all your time noticing, are we in a good space? Are we in a bad space? What happens when, every family reacts differently. So I remember I was having a real struggle with a baby that was having failure to thrive. And the mom we had to talk about, oh, there was some more weight loss today, and we're sort of only gaining 2 to 3 grams a day. Like, we're gonna have to work on this. And that mom was so tense and just dug in. I think she had heard this so many times in a way that never acknowledged her feelings, that she was just very defensive from the get-go. And I don't mean that in a bad way. Like, she wasn't a problem child or anything. Like, she had her guard up. And so noticing things like that is really important. And, in the meantime, getting as much of the backstory as you can. And then that leads right into this. So how do we find a non-judgmental starting point? Families are in a lot of distress right now. And so I'm just giving a ton of grace to everyone. I really want to prepare myself and bring my best self to that conversation. If I'm an externalizing person, which I am, but other people may not be, I might want to discuss this with a colleague and say, hey, I've been noodling on this situation, and I can tell this family's really struggling with this diagnosis. Let's talk about it. And then examine what has already happened, kind of in their long journey, like the mom who's been dealing with failure to thrive for 21 months and feels like a failure because food is love in her family. So what has happened to them, how it affects them, and then what this engenders in you. And I think all of us can acknowledge there are certain families, there are certain patients that are our kryptonite. And so just understanding what triggers me, and then understanding that's about me, that's not about them. So if I have a really tough dad who wants the expert in everything, and that's triggering to me because I'm like, dude, you got the expert. That's my problem. That's not his problem. So how this involves our own identity, and then decide what purpose we're going to have when we go in to work through this conflict. Like, do I want that mom who has the kid who isn't gaining weight? Do I want to have her agree to an NG tube or a G tube today? Or are we just setting the stage for further work? What is our purpose? And really tailor how you're going to have this conversation to the purpose that you want to engage in that day. I try to not come in with a preset, predetermined solution. I try to really leave that till after the conversation, because I know that families bring a lot of good information to the table. And so if I'm sending you home and I'm saying you have to do continuous feeds at home, but you don't have electricity in your home, and I don't know that, like, that conflict is never going to be resolved. And I'm going to label you as non-compliant when really it's like you're doing the best with what you have. So that leads us into the next thing. And I really try to go into that room like as calm as I can. I have a little ritual that I do to just take some calming breaths, and then go in and say, I'm going to listen. So this is our first active step. We go into the room or into the house and we listen and acknowledge the other person's viewpoint. So I might go into that room where that baby's, got failure to thrive, or growth faltering as we call it now. And I might say, hey, I noticed today that it seemed like you were a little bit upset with when I gave those weight measurements. Tell me what you're feeling, what's going on. I want to know your journey and your story. Okay, so we are worried that families are going to go on and on for 5, 10, 15 minutes that we don't have time for. In reality, they'll talk for about 1 minute and 20 seconds if you let them. Now, we pediatricians, we interrupt within 11 to 15 seconds, and we're better than other doctors. So I know all of you are better listeners than we are, but when I'm listening, I try to make it really active. I might take some notes. I'm not preparing any kind of counter argument, though my brain really wants to go there. I'm listening for the story of what happened. I'm listening to how the emotions are generated for that family. So, if that mom tells me, like, in our culture, the way you show love is through feeding, and there's nothing more loving than a chubby baby with big cheeks. And here, I have this tiny girl, and my whole family thinks I'm doing something wrong with her. And so that's involving her identity, right? That's shaping how she views herself. That's shaping how she thinks that family and friends are seeing her. And I'm not just mirroring her words back to her when I'm doing my reflective listening. I'm really synthesizing there. I'm showing I understand her view and her emotional reaction. And, you know, I may synthesize it. Like she might say some other words about food is love, but I may synthesize it to like, sounds like food is really important in your culture and it's really a reflection of love, you know? Oh yeah, you're getting it. You're hearing me. So in this step, I am not putting in any of my own information. I am purely synthesizing what they have said and what they feel. So still not putting in my viewpoint. It is really easy for us to jump straight to that viewpoint. So I'm really trying to emphasize how much we're not there yet. And then you really want to, before you put in your input, you kind of want to reframe and identify the root of the conflict as a shared interest. This is where you can share your views and your concerns. You can use some problem-focused language. But you can see we already did 3 whole steps in this, and we haven't put in our opinion once. So it's really great, and we do really well when we are able to do that nice synthesis for them. And then if that synthesis was spot on, you can just use that, or they may clarify it, but you can use that summary to say, it sounds like we're both worried about how your daughter's doing right now with respect to weight gain. And that it's really important to you to show your love for her through foods that you give by mouth and not by a tube. I wonder if there is a way that we can, you know, accommodate that and make sure she's getting the calories that she needs. So we're using really problem-focused language. We're acknowledging those emotions. And, you know, I could even throw in there, like, I'm really worried that if at this point we don't figure out a new way to get calories in her, you can see that her head size, her head circumference is, you know, falling off the growth curve, and her length is falling off the growth curve. We want her to be the best so-and-so that she can be. And then I can't emphasize this enough. Can we brainstorm options together with them? So rather than jump right to, I want to put an NG tube in your baby, or I want to put a G tube in your baby, say something like, so I'm sure you've heard some recommendations around this, and I wonder what you're thinking is the best way to do this. And in the case that I'm sharing with you, this mom was like, well, someone talked about power packing, but I could never really figure it out. And so we haven't done that yet. And I'm like, well, wait, that's a really big first step that is going to hopefully negate the need for an NG tube or a G tube. Like, let's teach around power packing. Let's get you into a nutritionist. Like, this is super cool. You haven't done that yet. Let's do it. And then showing respect for the family by considering those alternative solutions. Like, she is so afraid of that G tube. Like, let's talk about power packing and G tube, anything else first. And I'm willing to try anything for a time limited trial. I won't let it go on for months and months, but sure, if you want to try, you know, therapies that incorporate something that maybe isn't evidence-based, that's okay. Just keep it time limited. And then if you've appropriately identified those shared goals, those solutions will rise to the top. And don't be afraid to be creative about them. So that's my favorite part. And then best interest. We have to recognize that each person, if you really understand their pillar of the house model, like you're going to understand that it's, you know, someone's best interest is going to be maybe different than what you think their best interest is. So how can we satisfy the needs of all the parties the best? That's where the real win is. That's where we pull in our collaborating skills. And then you need to be clearer on what options you can live with. So if you're doing a feeding therapy and that baby is frankly aspirating in front of you and you're watching that happen again and again, you may not be able to tolerate like, oh, that's okay, we don't need to do a swallow study. Like that just might not be the safe thing to do. And so we all have our hard stops. And so I don't want you to feel like you are compromising yourself to the point where you're not doing what you need to do. Any questions about that? That's the rubric. And I hope everybody, gets these slides. Janelle has them. But if you could work on one piece of those through each situation that you encounter in the next week, and, there's basically 5 steps and you can try those 5 things. I feel like practicing that will give you really strong muscle memory to go into these conversations with more confidence. So does anyone have questions about that rubric? So you may say, okay, that's great, but sometimes we have people who are just not like rational actors. They're just not putting their best foot forward. They're not meeting me where I'm trying to meet them. If you find that to be the case, it is always okay to tap out and say, you know what? I can see this really upsetting. You've acknowledged the emotions. Why don't we just circle back to this next time we get together? And I love that because tincture of time sorts out a lot of what was just a bad day versus what's something that's going to be ongoing and more intractable. So a sense of timing, maybe getting help. So I do a lot of talking to colleagues about, hey, I have this family that's refusing vaccines now. They had vaccinated all their other children. We're really at an impasse. Do you have any ideas? Really try to depersonalize the issue and realize that all of us are reacting from a place of self and sometimes fear. So don't take it personally. I'm pretty self-effacing. And so for me, my way to diffuse tension is to be very humble and say, you know what, I really messed that up. Can I try again? Or whatever it is to diffuse those tensions and sort of reset. Time is also a great reset, taking that break. And then putting the onus on someone else. Like, okay, we've talked about this a lot today. Here's my assignment for us. I'm going to take a step, and next time we meet, I'm going to bring 3 possible solutions. Would you like to do the same? So that again, we're going back into that collaborative mode with them. There are times, rarely, and I think using these techniques, it becomes even more vanishingly rare, considering a transfer of care. So if you just can't work it out with a family, and I have a psychologist friend and she says a great thing. She says, sometimes we're just Swiss cheese. Most people like it, but some people just don't. There's no figuring out why. It's just Swiss cheese. So in those cases where we're Swiss cheese, we could consider transfer of care to another provider. And that is no failing on our part or on the family's part. Sometimes we're just Swiss cheese. But if you are making that transition, please make sure to maintain trust and follow through. And I know that if someone's, let's say, switching from me to another provider in my practice or something like that, that I'm trying not to give my filtered response of like, oh, well, they're just X, I want someone to have completely fresh eyes and a blank slate, so they're not coming in loaded. If someone hands off to me and they say, oh, you're going to coach this medical student, but they're so bipolar or they're so flighty, like, isn't that going to change the way I coach that medical student? So I try, just as a courtesy to myself and others, to not load the situation when I'm handing off care. Okay, so considering power differentials. We are all, every conflict we have, and this holds true for you when you're having conflict with your own leadership and stuff like that. We really catastrophize our conflict in power differential situations. So I want you to be realistic. I know that I can get myself into a place where I get myself worked into a complete tizzy about this person thinks that about me and I'm going to lose my job. And, like I have to fight this radiologist. And I can spin that situation into something that's really out of control in my emotional world. And for the other person, it's often just like a bump in the road. So be realistic, use your great sense of timing as an avoider, articulate things as shared goals. So I talk a lot about, especially during COVID times, like our work structure all changed. And, when we came back together and the work structure changed again, we all had to negotiate for what was going to work for us. I try to articulate those things as shared goals. And I say things like, hey, my research really took off during the pandemic. I wrote 6 papers and I really like to continue that momentum. Is there any way that we can still make sure all the patients are seen, but that I get some protected time to continue that writing flow? It's easy to articulate something that way. Making sure to validate the other person's point, and that's true in any conflict situation. And try not to judge if someone's telling us no. They probably have other concerns that they can't fully articulate to us. So I find, especially like with my med students or my residents that I'm working with, that sometimes we say like, no, you can't have that day off. Like they might not be aware that you have 3 residents out with COVID and someone's taking a test. And so I really try to encourage people not to judge if they don't get the answer that they want. And we're going to stay calm and we're going to stay humble. I know I can get flooded and pink, and I just acknowledge that and kind of let it go. It is who I am. So, but we are the person in power the majority of the time we're talking to families. They really see us as authority figures. And we want to create for them an environment of psychological safety to be able to speak up. And how do we do that? We need to be vulnerable. We need to allow for that transformative dialogue to bubble up. So if someone tells me something, I'm thinking of an example with a speech therapist where things just weren't working between the child and the therapist. Like sometimes we have to have that hard conversation of like, hey, this child gets really flooded when someone is very loud. Are we able to do something so that the environment's a little calmer, or should we consider a transfer of care? Because like that's just the way I am. I'm super loud. But creating that environment of safety. Again, as with the house model, this builds over time. Like it's not like you're going to make a psychologically safe environment for a family on visit number 1. And that's why I encourage people to use these techniques from the first time they meet someone. Don't come in with those preconceived solutions. The worst thing is like a top-down solution, and people from the grassroots feel like they don't have the space to bring up their own perspective. And the best transformative care models all come out of us working together from the top and from the bottom, and then providing space and silence to empower people to speak up, because all of us are better together than we are one of us alone. So let's see. I just keep losing cursors and stuff. So these are my kiddos. This is my little guy with Fragile X syndrome. His name's Theo. Kristen was one of the first people to ever work with him, and truly, truly one of the best. She certainly made our life more hopeful and amazing. He's in a combined classroom where he's like mainstream with supports. So he's doing really beautifully well. And I have to say, it was all thanks to early intervention. We really struggled after that as we transitioned into the school system. So our early stuff really changed things for us. These are my 2 older, now teenage daughters. And if anybody told me how hard teens were, I might not have had 4 children. And this is my little caboose, Frankie. So I'll pause here, see if anyone has any questions, and then I know you have a lot of other stuff to talk about.
Well, I really appreciate it. And I'm just going to warn you that then comes adult children, and those are harder too.
Don't scare me. That's already hard.
It's what was that you said, being open and honest about that?
Yes,
So
I'm ready for it.
Adult children are the worst, Janelle. They're the worst.
agrees with me. But I really, the big thing that I took out of that, and I want to practice saying that, is that I wonder if this could work. I really liked that phrase with
Yeah.
it.
Yeah. And we say a lot of the time, we say, tell me more, so that we get better at understanding where the other person's at. We say, I hope that's the case, because we have a lot of magical thinking. I hope that's the case, but I worry that something else might happen. And I wonder what, allowing the space to have that wonder.
Yeah. Anybody else have any thoughts or questions? Okay, and Kirsten, it's not that my older children are not amazing. They're just a lot harder.
Well, mine lives in Ireland now, so I get to just go to Ireland and visit her every few months. So it's awesome.
Okay, well, that would be good too. Okay, well, if nobody has any questions or comments, I am going to try to find Crystal on my screen. We're going to do something a little different for case presentations today. We are just going to be talking about some families that we have had from our hub members, and then we're going to be discussing them as a large group. So Crystal, I'm calling you out first, and you're going to present your case.
Okay, so Brianna's on here too. This is actually hers. She might be able to
Okay.
speak this better than I can, but Brianna, do you want to talk or you want me to?
I would like you to talk.
Okay. All right. So this is a case that we had. It was an infant that was referred to us from the NICU at the local hospital due to an array of medical complications. Services were put in place, and the family received services for hearing, vision, occupational therapy, developmental specialists, and of course, service coordination. The team offered support in all areas for things, and things were progressing slowly. However, medical issues were severe and involved babies feeding and breathing. After the family had visited with several specialists at the Primary Children's Hospital, the baby was diagnosed with CHARGE syndrome. We've served children with this syndrome in the past with success and in developmental progression on individual timelines. During the family stay at Primary Children's, further testing was performed and results were discussed with the parents. The family was informed by the medical team that the baby would forever need to be tube fed, remain on oxygen supplementation, would never walk, talk, eat, or care for himself, and his life would be shortened due to the severe brain malformation. Breathing was a significant issue, and as even with supplementation, he would forever struggle to breathe. Baby's parents made a difficult decision to remove all support and only ensure that his body didn't feel pain, as they believed that this was a journey that their son had chosen to take. So the struggle for us in this situation was we were all on board to help and progress, and there was a lot of hope in the team. And then the struggle was to get behind the parents in their decision. And even amongst the team, there was a little bit of a discrepancy in what providers felt. So that's our scenario.
Yeah, it was a fairly big team, considering. And again, there had been success with several children with CHARGE syndrome. And so I think that played a part in it with the team, where it's like, but things were moving but it was harder for some than others to get behind that decision.
Yeah, that is a tough one. And so thinking about that scenario, I'm going to open up this question to all of us on here. How would you all approach that to support your team as well as support the family? So Rihanna, I don't know if you want to share an idea about that.
Well, it just came natural to me to, I will back my parent with their gut feeling, no matter what they decide. I would have backed them fully either way. So I didn't have like a conflict with that. I was right behind them because I had already developed that foundation of trust. So that was mine. And then my team members, they struggled, and I would try to point that out in conversations about the importance. The parent knows, they know.
Yeah. So you all know me, I'm not opposed to calling on people, so.
I'm happy to say something, but I don't
Yeah.
want to step on anyone's toes. I'm very much an information gatherer, so I think I would like to touch base with like the Primary Children's Rainbow Kids team and make sure that I understood how things unfolded for the family. And I think bringing that kind of information back to our team would really help to inform like the decision making without forcing the family to have to rehash that whole thing or feel like they were questioned. So I'm an information gatherer that way.
Yeah, and I think that's a really valid point that we sometimes forget is that to support a family, we want to reach out to other people that get that information, because sometimes if we've all had difficult conversations on the medical side, or not even on the medical side, you're being thrown all this information. It's a lot to take in. I might have misunderstood something with that.
That's exactly the case too. One of us kind of misunderstood the whole situation, and that is what occurred.
Yeah.
But it
So
wasn't with the parents, it was between like the team members, but it helped back up the parent.
yeah, that's great. Janelle, just because you have always the same name as me and spelled the same, how might you handle that conversation or that situation?
You know what? I really, really like the information gatherer thing that she said, because if I don't know, I mean, I'm still going to support the family regardless, but to have that information so that I can understand why they made the choice they made, and be able to support it with actual facts, that would help me keep it out of the emotional realm by using facts. So
Yeah. That's a great
Janelle, you said something interesting, Crystal, when you were talking about it. You said you'd worked with a lot of kids with Charge syndrome before and had been successful. And that kind of stuck out to me because success looks different for every person. And I think that's a critical thing for us as providers. I mean, maybe I've been working in this field for 25 years and I've worked with these kids with Charge syndrome, and I feel like we've been successful because we've hit X, Y, or Z milestones and this and that and the other. Sometimes I think, depending on where that parent is emotionally, maybe the parent has 6 other kids and this kid is sucking 98% of the time. They're making progress, but is that success because the rest of the family? So I think looking at it holistically, it's hard because you're supporting, the family who wants to go this direction and the providers that are saying, yeah, but we can do this. That's such a hard balance. And I've been in a lot of those situations in my career where I'm like going, I think you ought to really do this, but the parents are going, and we want to do this. And you're like, okay. And so you support and try to continue to educate and try to continue to share expertise. But it's so hard because that word success is so different for every person that you deal with.
I agree. Other things on this particular case presentation that we would maybe think about or do differently? Rebecca?
You know, initially, the one team member felt like it was a case of medical neglect and that it might be something that she needed to report. And so there was a little bit of that moral issue playing into it, which I think she was satisfied with more information. So that information gathering is what put her at ease. But sometimes there's, you know, where's the defining line of what is enough to do for a child and what not to.
Right, and even utilizing some of those skills that Victoria was talking to us about with our colleagues too, getting us all on that same page, because it's that secondary trauma that we, you know, we all experience. So I think even listening to some of the things you've talked about, those are really great skills to then bring into this conversation with our colleagues. So.
And that's why I always now include the piece about power differentials, because I think more important than preserving relationships with families is we're all going on to work with each other day in and day out. Preserving our relationships with our colleagues is utmost importance. So that's why I always include that.
Yeah, great. Okay, I'm going to move on to Shelby. You're now on screen. Do you want me to still say Rebecca's sharing? Okay, Rebecca, you're up.
Okay, do you want me to share the PowerPoint then?
Yeah, go right ahead.
Okay.
I would try, but I don't want to jinx myself.
Can you guys see it?
Yep.
Okay, so we'll try to get this in. Oops, that's not what I wanted to do. Okay, so just a couple of slides here, just to give you guys a visual. So we're taking the topic of how we would have the conversation with a family when we suspect maybe a child has autism spectrum disorder. And so what we did was kind of combined from our experience of things that we've seen with children and created this case scenario. So Jacob, 24 months old, was initially referred to early intervention due to communication delays. Parents report that when Jacob is excited, he flaps his hands and vocalizes "dugga dugga dugga dugga" repeatedly. His parents have asked on various occasions, why does he do that? Will it eventually go away? Jacob does not have any true words, which leads to several meltdowns per day since he cannot tell his caregivers what he wants. Parents also wonder if Jacob will ever talk. Jacob rocks and still relies on the bottle and/or pacifier to self-soothe. He is a very picky eater and only eats while watching his favorite show on a tablet. Dad frequently asks, will he grow out of it? Jacob struggles to fall asleep and sleep through the night, and his parents report he's never been a good sleeper. He's always been delayed in meeting his motor milestones, and Mom thinks he's just lazy. So I loved the information Victoria shared today. And I think too, like when I would approach that conversation, I would always keep in the back of my mind, the parent might have already been thinking about autism spectrum disorder, or they could be completely blindsided by it. And so we don't really know starting that conversation. And so maybe some of those questions and points that we heard today would be helpful. But after learning more about Jacob, as the early interventionist, you're very concerned that he might be a child with ASD. And so how would you respond to his parents' questions and concerns? So just kind of looking through the list of the things the parents might ask, how do you think you would respond?
So how about Tammy? You're on my screen. What do you think you might do in this kind of conversation?
Stop sharing too.
Okay, now it moved. So I will call on somebody else. Gabby, what might you do in this type of conversation? Tammy just said I can't talk right now. Thanks, Tammy.
What did you say?
Tammy just said she couldn't talk. So I said thanks for responding, Tammy. So Gabby, what do you think you might do?
Well, I would probably kind of gather some more information about the family and what they know. And I would go probably find a way to say what the vocal stimming could be indicating and sensory input. So I was going to go around those indicators first and name them. And then I would say that those are some early indicators that I'm not saying the child has autism or doesn't have autism, but we were opening a conversation that will never close. And we would kind of take notes of some of those indicators and think what they think about it. Give them some time. Maybe in the next visit, we can go back to those early indicators and see what they think, what they observed, or maybe we can get I do a lot of like checklist with some early indicators. So I could probably say, okay, so these are the indicators. Next visit, then we can work on, thank you, Shelby, for saying that. So I lost my track of thought.
There you go. Those are great things, having that open conversation.
I can give you some input. I just
Yeah.
have been listening and thinking. So I often end up in this conversation. So I have my autism certificate. And so I'm usually the one that gets brought in, usually in a consultative role. So I always joke with my coworkers that they brought me in so that they don't have to have the hard conversation first, because I'm not always with the family. And I've had a situation where a family actually fired me for having the conversation with them. And I was like, that's fine. 2 years later, that mom called me and their daughter had an autism diagnosis. And she kind of was like eating her words, but I was like, I was never mad. You get to choose what's best for you anyway. So you're never going to hurt my feelings. But oftentimes what I try to do, because they bring me in for an OT consult. And so then I'm the one coming. I usually like to bring, and not necessarily call it this, but I bring the MChat expanded version, because I love how those questions dive deeper, more than just, the MChat's yes and no's. They don't give you a lot of information, or parents don't understand what that could mean. So I'll go through that, expanded version, and then I'll talk about what it was. And, and oftentimes it's not new in the parent's mind. It's just something they haven't said out loud yet. So then, that first time I'm there for an OT consult, we're talking about what are maybe the sensory things they're seeing. What are some of those red flags that maybe pop up on the MChat? What could that mean? And then, they usually bring me back for a follow-up a month or two later, because then the parents are going to have a ton more questions and whatnot. But I really like to focus on, like, what do you notice about your child? What are things that what are the things that you love, focusing on that positive first? And then what are the things that worry you? Okay, well, here's what some of those things that worry you can mean. And also talking a lot about, like, here's what's available if you are concerned about this. And right now, early intervention is one of the best things you could be doing for them, because you're learning as a parent the tools you can use, because you're with them the most. You can take them to outpatient, you can get all these other services which are beneficial, but what you're doing at home is the most important for helping you provide the best environment and the most efficient learning style for your child that you can at that point. So that's usually the conversation I have with families.
Virginia, you just totally nailed it. Like, you really met the parent where they were at. For me, I feel like if I'm bringing up MChats and like, oh, I did a posy and I got this score on this, and I start getting into numbers, like I feel like I've lost the parent. So I really try to like focus it back on that most basic level. And I might say things like, I'm noticing that your son has some differences from other kids of his age. Have you noticed that? And kind of see where they're at. And if they say no, then you know that you're going to be tabling that conversation and introducing it slowly. But if they say yes and they're like, oh my God, I'm so worried he's 18 months and he's not feeding himself, or, you know, whatever, then you already have that starting place. And, you know, like, especially in your setting, you're not the diagnostician, right? So I don't know how helpful it is to say, like, I'm concerned about autism, but to be able to say, hey, we have those resources and I'd love to refer you to UDAC or, you know, whatever the local diagnostic authority is. You know, you've just presented like the problem that they've noticed and a solution. So that can be helpful.
Yeah, and like I said, that's why I like to use the questions on the MChat without really calling it that, just because I like the expanded version that gives like, are they doing this? Yes. Okay, well, if it's a yes, well, let's go a little deeper into that and what that's going. And I can see Rebecca Foster on my screen, so I know she'll agree with me, but that's the one downfall sometimes about North Dakota is there's not a ton, and I'm in rural Southwest North Dakota. So like the closest is Jamestown, really, when you get to the Ann Carlson Center for us, and then Fargo beyond that. So, you know, having that approach, especially in early intervention, of families knowing like we're here to support you and find as many resources as you can, but in that birth to 3 world, getting them started here is the best that they can do for their kiddos. So, you know, those are the families that oftentimes are going in, they're like, well, they're every other week. Okay, well, what can we do to help them move to more frequency with visits so they're getting more support, adding more consultations and things like that, just to give them way more, you know, tools and resources in their toolbox to be able to use with their child.
Yeah.
One thing too, as an opener, you can ask them what their pediatrician has or has not said about their questions.
Yeah, they're good. Yeah, opening that. I also really liked what Victoria had said, is really dealing at that emotional level first and sitting with the parents on how they're processing that. So you have these questions. How does that respond to you? How do you feel about those? What would you like to change or target first? Other ideas on how you might have that conversation? Shauna, you're on my screen. Do you have any ideas?
So I actually do the MChat completely opposite, and there's no right or wrong, but what I'll do is before I express any concerns for autism, I'll say, this is a screening. We do it with all our 18-month-old kids, and it's just to assess to see if there's any risk for autism. And then as you ask those things and they realize, wow, my kid is hitting a lot of things on this list, then we have that conversation, and it doesn't feel like I've targeted their child, because we do this with all the kids.
Yeah, that's a great one.
Yeah, we use that approach a lot in our program, Shauna. Just tell parents, you know, we do this screener with all kids that are in that 18 to 24 month range. And yeah, and that it's nothing that we would ever use to diagnose, but it is a good conversation starter for a lot of families.
See all these amazing people on the call that have great ideas. Michelle, what about you? Michelle Burton. Oh,
there it is. Somebody else mentioned cursor issues. I'm having cursor issues. This is not my strong suit. I'm a physical therapist, so I'll say I know it comes down to meeting the family where they are. So you got to ask more questions. You got to present objectively what you're seeing, because we don't want to withhold that information, and then respect wherever the family is at that moment. If they're not ready to receive it, say, hey, I'm here. if questions come up. If they are ready and they have questions, and I would say, hey, I have a great autism specialist who can come in and do an assessment, and we can start talking about that process, or not, whatever the family really wants to do.
Yeah, great, meeting them where they're at. Perfect.
Oh,
All
thanks,
right.
Victoria.
No, thank you. Okay, Kurt, we have one more case. Then Kurt is doing our next case. I think it's on a medically complex child.
You guys see my screen okay?
Yep.
Good. So I'm Kurt Phillips. I work with Janelle in the ECHO project. I'm also a physical therapist by profession, and just want to share a case that I had with a kiddo that actually a family, and the questions you'll see kind of center around the family as much as the kid, because I think that's critical to the care of the kid, is making sure that the family, and particularly the primary caregiver, is taken care of. So this is just it's a young family. They have three total kids. The oldest one passed away when he was about 4. He had a significant disability with a lot of seizures, multiple seizures each day, was never mobile, was fed through a tube, and had very little communication. Obviously very difficult. It was a young mom, probably in her early 20s when she had this little guy. And it was pretty much around the clock care because of the seizures, because of his needs. So it put a lot of strain on mom and dad early in their marriage. He had multiple doctor visits each month. Often he was down at Primary Children's getting care from their amazing team down there. That was both time consuming and financially difficult for this young couple. When he was still alive, he had Part C services, including PTOT, speech, vision, along with other services kind of here and there as he needed them. Lots of appointments, multiple appointments each month from the Part C folks, as well as when combined with the doctor visits. A lot of times they would have multiple appointments each week. Mom and dad were told by the doctor, and this was a specialist, that this was just, I don't want to say a fluke, but it was a one-time shot. They had no greater chance of having another child with this disability if they were to have more kids, and so they decided to have more kids. And they had a child who doesn't have a disability and is doing great. And then just after the older son passed away, they decided to have another kid, and this third kid had the same disability as the first one. And so obviously a lot of strain. Dad works outside of the home. He a lot of times works long hours, so mom's at home with the kids by herself. So these were some of the things that, as I talked to the mom and as I worked with this mom, with the first kid and with the second kid with this diagnosis, the mom really had a lot of difficulty managing her emotions. First of all, the doctor had said, the chance of you having another child with this same diagnosis is the same as anybody else. It's not a genetic thing. It's not anything that, because you and your husband have these genes, that you're likely to have another kid with this disability. And so she felt like maybe the doctor wasn't completely honest, or that the doctor wasn't completely informed of this disability. Also had guilt of having this other child with this complex disability, because it didn't allow her the time to spend with her family, her husband, and the child that didn't have the disability, because she was constantly caretaking for either the older child or their third child. And then also the emotions regarding how her husband had kind of checked out. With the first child, he was fairly involved, but when that second child with the disability came along, I don't know if he just couldn't handle it emotionally or what, but he started working longer hours and started not really being present when he was home. And so the questions I would ask are just these 3 questions. What strategies are there to make sure the mom can spend time with her other kids and her husband so they don't become respectful? And I put the name Bob in here. It's obviously not his real name, but resentful of the extra time they have to spend all the time with this one kid with a disability. What can be done to alleviate the guilt mom has for having another child with the same genetic-based disability? Even though we all know it's not her fault, she still carries some of that guilt that, maybe there's something wrong with her, or with just things that she didn't have control over. And what about the anger toward the doctor and the medical personnel? And then how does a mom show patience with her husband when she feels that he's checked out when he's at home? And these aren't questions mom's necessarily asked me, but they're questions that as I work with mom, I can see her not saying them, but really having these concerns. So I'll just leave this screen up and just love to get some information. I am working with one of their children right now, and so it is a kind of an ongoing case that I'd love to have some input, because I am not a counselor by any stretch. And so this whole dealing with how do we help mom overcome these little emotional obstacles she's having, not little, significant emotional obstacles. Any thoughts?
Gabby has said it looks like connecting them with a family place for family therapy could be helpful.
Okay, that's a good thought.
Is respite an option?
Well, the family place, I think, does some respite. I think for short-term respite. Problem is, these people live quite a ways away from where the family place. They're about 25 minutes. They're on the way outskirts of our catchment area, but that's a good opportunity, the family place.
Hey, Kurt, just on that thought of going to in-person family therapy, you know, our area, we're so rural, we have a psychological consultant on staff, and she actually is in Salt Lake City, and we're not, we're far away. She does her consultations virtually, but actually has found families prefer to do them by phone, because they can still be around the home and not have to take away time from the kids. It's surprisingly helpful to have that virtual therapy option to support literally all of those questions. But your respite care is a challenge.
Well, and I was talking to a family, they have the medically complex child Medicaid, and they get several hours of respite care. And they were able to pick their own in person. They were able to get a nursing student. And if it was a nurse, they were able to pay them more through their medically complex child Medicaid.
Perfect, thank you.
And I had another child too, and they were able to just hire grandpa through the respite care. And then they didn't have that guilt of having a family member do it just on their own time. But yeah, family to family network, DSPD, but that has a huge wait list, and it sounds like this kiddo. But yeah, I get signed up for the DSPD because they have respite care too.
Great suggestion.
Kurt,
Rochelle,
are you,
Hi.
oh, sorry.
Oh, sorry, excuse me. I volunteer for New Mexico Make-A-Wish. And it is not an organization for quote terminally ill children, but life-threatening conditions. And they've done beautiful things for families. So maybe getting in touch and making a referral to the Make-A-Wish organization, and they would work with them as a family to look at like a potential wish. So like just off the top of my head, a common one is for families to travel to give kids the world in Disney World in Orlando. But it's something that's created, and all their medical, like if the child's allowed to travel, it's all paid for, set up for them. They can go and enjoy themselves. Because statistically too, families with medically fragile children have a very high incidence rates of divorce. So maybe having also the parents having a date night might be a possibility too.
Yeah, going to Disney World would be like the last thing on my wish list, but I know a lot of kids do love that place. Thank you for that recommendation. I love it.
Kurt, have you been able to surface some of her concerns? Like, I know a lot of the families I work with, especially I do a ton of rural Idaho, Wyoming, Montana. Like my kids come from far and wide for Fragile X Clinic, and like getting some of these families into therapy is just like a non-starter. But the one thing they do is they trust me, they trust my team. And so being able to surface some of that, like I have a family that's north and they have 4 children with Fragile X syndrome, you know, and just being able to check in with the mom and say something like, gosh, it seems really hard for you right now. I'm seeing that you're carrying a lot of this load by yourself. Like, how are you doing? And not that we're going to be her therapist or something, but just to have that pop off and that sounding board can give her so much peace of mind.
I love that, Victoria. You know, I don't want to sound like I'm making excuses, but the moms don't tend to open up to me like they do to the female caregivers. But I love that idea of maybe grabbing somebody else on the team that she might open up to. I just found that I'll be talking to my teammates and they'll say, oh yeah, mom said this and this and this. And they're questions that I've asked a mom and mom's like, it's okay, you know. But then when somebody else asks, it tends to be, but I love that idea of trying to bring up and figure out what exactly those issues are so that we can help however we can. We do have a social worker here in our program, and so that might be a way to get the conversation started to figure out what those things are. So thank you.
Well, I love it. And so I love your little challenge to us. So, and maybe it was just to Kurt, but I'm going to say it's to all of us, that we need to stretch those muscles and pick just like a little tiny topic and move forward. Because I know that all of these scenarios, we probably encounter them on a weekly basis, if not daily, that we're having some of those difficult conversations with the families we serve as well as our colleagues. So I loved some of the strategies and suggestions that were presented today. I'm going to wrap it up and just say thank you all for joining. Our first 4 months of this series are all around navigating family conversations. So next month we will be having some families actually come and present to us about what they would wish that early interventionists knew from their perspective. So it's going to be a great one on that one. And then that will be in March. So March 5th. Thank you all for joining us, and we will see you next month.